That's left. I'll just briefly go through the tips of perimetry.
Yes. Dr. Pranav Ranjan is going to present on the topics of perimetric pearls. He is a brilliant practitioner in the Patna, from Patna, and he has passed his MBBS and MS from the Patna, and now he is the president of Bihar Obstetric Society and also the AIOC Society of for Eastern Zone Society. It is a very upcoming society, and he is the president of that society. Now over to Pranav Ranjan for.
Thank you, Dr. Agarwal. Perimetry, we have to consider few facts before we go into the interpretation. We get into certain definitions like threshold. What is a threshold? It is a particular intensity of light which is seen 50% of the times. Supra threshold is seen 90% of the times, and infra threshold is seen 15% of the times. There is a stat pack analysis which is done with the Humphrey, and it is a computerized software which is based on normative data. The 5% lower normative data is bracketed as abnormal, and what we do is we compare the normative data with the present data that is collected from the present patient. This is also important. P-value is important because we have to interpret from the p-value also. And what is a p-value? It is a probability percentage. What is a probability percentage? It is assigned as 10%, 5, 2, 1 and 0.5%. For example, what p less than 1% means? P less than 1% means that this defect is seen only in 1% of the normal population. Other way of describing it would be, it is not seen in 99% of the normal population. So you have to consider this. There are two aspects when you are doing a autoperimetry, that is a point pattern, the point in which the tests are done, because this is a static, automated perimetry is a static perimeter, and the strategy, what kind of a strategy of throwing the light is given to the patient. These are the common test patterns which are followed in glaucoma. 30-2, which has got a 76 test points, 6 degrees apart. 24-2, again, which is a shorter form of 30-2, which has got 54 test points. Both of them are of equal value, but the advantage of 24-2 is that it takes lesser time, and the sensitivity as per the glaucoma is concerned is almost equal. So we generally prefer a 24-2. For advanced glaucoma, we have a 10-2 point, which has got 68 test points with distribution pattern of 2 degrees. Macular program is just 5 degrees and a nasal step. These are all the tests which are confined to glaucoma testing. The second one is the strategy that we have to take into account. We have two strategies. The older strategy, which was known as the bracketing method, and the newer strategy is the new threshold strategy. In the older strategy, the stimulus used to travel 2 times across the threshold value with a value of 4 degrees apart, and then while descending back, it used to reduce by 2 decibels. So it had to cross the threshold level twice, but the final resolution was 2 degrees, 2 decibels. Whereas the newer threshold, it crosses the threshold level only once with a decibel difference of 3 decibels. So the final resolution is 3 decibels, but the results that we get, we save at least 40% of the time, and there is hardly any significant change in the final outcome. These are the checklists which one has to take into consideration, and we'll just go into the single field analysis which we see in the Humphrey field. For convenience sake, we have divided into 10 brackets, 10 groups, 1 to 10. The number 1 in the single field analysis, the area 1, which has the name, age, I selected, and the test which has been selected. One thing which is important is to enter the correct age, because the correct age of this particular patient is going to be compared with the normative data which is already stored in the computer. So the age has to be correct. The second area is the area of reliability factors, whether the patient is able to concentrate on the central point or not, is losing his fixation or not. So we have got 3 points here. One is a fixation loss, the second one is false positive, and third one is a false negative. What is a fixation loss? Is measured by placing 5% of the computer places 5% of the total number of stimulus that is given to the blind spot. Any error which is more than 20%, we cannot take it, it has to be discarded. False positive means there has been no stimulus, still the patient has pressed the button, has a positive response, and anything which is above 15% is unreliable. False negative again is a missed response because of fatigue of the patient. Area number 3, 4 and 5 has the foveal threshold, the stimulus size which is standard Goldman 3, the background illumination which is standard 31.5, the strategy that has been selected, the Sita fast or Sita standard, the pupil size, visual acuity and the diffraction. Coming to area number 5, which is the most important area, this is the raw area, area of raw data along with the gray scale. So what it does basically, it gives you a generalized picture of whether the field is abnormal or normal by giving black to white shades as per the sensitivity of that particular patient. So coming forward to area number 7 is the area of total deviation. So area of total deviation is nothing but the point-to-point difference of the normative data of that particular patient in comparison to the present data of this patient. So what you see here, XXX is the normative data which is compared point to point with the raw data, and the difference between the normative and the raw data is given in total deviation numeric plot as well as the total deviation probability plot. So this is point to point difference. So coming to the pattern deviation numeric plot, this is derived from the total deviation plot. What is done is that the total deviation can be because of a sensitivity loss because of cataract, corneal opacity and vitreous opacity and other things. So that has to be differentiated and that has to be eliminated, and glaucoma specific can be done only when they are eliminated. So this pattern deviation numeric plot, by applying a stat pack analysis, that gives you the idea in numeric values as well as the probability plot value. And how it is done basically is that in the 24-2, which has got 54 test points, 3 test points near the blind spots are ignored, and of the remaining 51 points, the 7th best point is adjusted to 0 and the other points are accordingly adjusted. For example, what we see here is that the 7th best point in this total deviation is -6. It has been adjusted by adding +6. It becomes 0 on the pattern deviation, and accordingly the other points, like just beside -6 we have -3, becomes 0, becomes 3. So this is how it is adjusted. Area number 9 is the GST, which is the most important. It has 5 mirror images in the superior and the inferior sectors. They are compared to each other. This is very glaucoma sensitive, and it is flagged in by 5 definitions, like outside normal range, borderline, low sensitive, high sensitive, within normal limits. The area number 9 has got 3 parameters. The mean deviation is nothing but a single number which is an average of the total deviation. So what we see in the total deviation here, the average of all the points is given as a single total deviation point, right? And it is given as a probability plot, defined as a probability plot also. Pattern standard deviation is the difference between the mean deviation number and the pattern deviation number individually. So if there is larger difference, the larger will be the PSD, and the larger are the chances that the field will be glaucomatous. The third, which has been incorporated around a decade back, is the visual field index, which is expressed as in 0 to 10, 100%. 0% means blind, 100% means which is normal. It incorporates both the total and the pattern deviation data. It gives weightage to the pattern deviation and central points, provides an estimate of field loss in the next 5 years. Anderson's criteria, this is one of the most widely used criteria to define whether the field is abnormal or not. PSD depressed to be seen in 5% of the population. GHT outside normal range. 3 or non-edge points in pattern plot to be seen in less than 5% normals, of which one should be less than 1%. And it should be present in 3 consecutive fields. So these are just examples: inferior arcuate with a nasal step, inferior arcuate with a nasal step, double arcuate, advanced glaucoma with an annular scotoma, advanced field loss, annular scotoma again, a glaucoma with a cataract field loss is seen like this. This is a bitemporal hemianopic field, the neurological fields which you can see, the homonymous hemianopic field. This is a RP patient of 30-2 and full field, just a pattern. And this is the comparison between the normal and the abnormal. On the left side, what you see is the normal. The right side you see is an abnormal inferior arc with the nasal steps. Unless you understand what is a normal, you will not be able to differentiate what is abnormal. Thank you so much for your kind attention.